I'm Joe. I finished my MD PhD at the Center for Social Medicine about a year ago. Um, Finished my PhD in social medicine, and now finishing up my intern year at UCSD in the Department of Psychiatry in the research track. I'm going to be talking about some work today that I started while I was at UCLA in my PhD program. And then show how it's kind of continued to evolve since then. The talk is called The Arrival of Xylazine to Tijuana and Southern California, Clinical and Harm Reduction Implications. The title of this slide is basically taken straight from my dissertation. And the overall kind of model here, or the main idea here, is how ethnography can be used to actually make public health better, right? And I think I use ethnography as a tool, as a method. I think I often use it in a way that's a little bit different from like the kind of traditional approach of a lot of anthropologists, where a huge part of the goal is contributing to social theory. And that's definitely something that I've done and care about and I'm interested in. But I think there's this really fundamental way that ethnography can help public health, which is just like, you know, don't make massive mistakes because you have no idea what's actually happening on the ground, right? And just be kind of connected to the lives of people that you are ostensibly, hoping to help and hoping to serve in public health. So this kind of model, which I'm hoping to lay out and then like give an example of through xylazine, is I kind of like to call it blending ethnography and epidemiology. And then related to my research, it's to track rapid shifts in the North American overdose crisis. And I would argue that in the study of a clandestine or difficult to examine topic, such as like illicit drug use, the illicit drug market, that ethnography represents a manner of accessing common sense, on the ground logics and realities that can often be surprisingly difficult to characterize with traditional survey methodologies, right? I think this is a kind of a core insight from a lot of Philippe Bourgois' work. Which is basically just that if you spend time with people and follow their lives over time, you can kind of understand why a lot of like public health interventions may be failing them for super obvious reasons to them that are not obvious if you don't know the people. And then I would argue that the combination of ethnographic approaches with flexible epidemiological methods can allow public health research to be kind of light on its feet and rapidly track areas of emerging importance. So this model can be conceptualized with this diagram. I kind of, I think there's like different ways this could be articulated, like what should come first, quantitative or qualitative, The model that I most often find myself wanting to use looks something like this, where qualitative research can kind of give us an initial insight that something important is happening. And usually that insight is local in ethnography because you're doing ethnographic research in a very particular hyper-local context. And then if you pair that local insight, that qualitative insight, with some quantitative analysis, you can see, is that thing that's true in this little place that I'm doing my research also true more broadly? And then I think the real beauty of this approach is the ability to kind of integrate the qualitative and quantitative information to figure out what is actually happening in the big picture, but also why is it happening, right? And I think this is actually something that's really hard to determine a lot of the time with just quantitative methods. And you really need ethnography and other qualitative approaches to say, not just what is happening, but why. And then I think the model, to me, a very important part is dissemination, right? Is like getting the word out about this insight, and then constant reevaluation, right? In terms of like ongoing public health monitoring of this situation. And the cycle repeats itself. So today I'm going to be talking about xylazine. This is a medication, a veterinary tranquilizer. I would guess maybe a lot of people have now heard about xylazine because it's been in the news in a lot of like very alarmist and unfortunate portrayals, some of which you can see here on the screen. A lot of stigmatizing language and I think really unfortunate kind of classic war on drugs rhetoric. But at the time that I was setting out to study this topic with Philippe, who was my dissertation advisor, and with a number of other people, this was a relatively unknown quantity. So what is xylazine? Here's a picture of a bottle of xylazine, veterinary xylazine. So xylazine is actually a veterinary sedative. It's an alpha-2 analog agonist similar to clonidine, but it's unlike clonidine or dexmedetomidine, Precedex, or other alpha-2 drugs. It has never been approved for human consumption due to dangerous side effects. Um, it causes rapid sedation. That's the main thing. It's used in, as an anesthetic. So it just simply causes somebody to be unconscious. It also can cause hypotension and bradycardia. And it's been very clearly associated with terrible skin wounds in a long history of qualitative research working with people that use drugs. Here's an example from a published report of some xylazine-associated skin wounds. They're a little bit atypical from like normal abscesses, and they're described as like massive kind of ulcers and soft tissue destruction. As I'll present later today, it also is associated with an increased complexity of overdose management because xylazine as an alpha-2 agonist is not in any way responsive to naloxone. So it's been noted in the illicit drug supply of Puerto Rico for about two decades ago. Then it spread to Philadelphia about 10 years ago and is now spreading across the US. And xylazine can take many forms, but here is just an example from some drug checking data of a sample that was 8% fentanyl, 30% xylazine, and just sold in Philly as just dope, just generic street opioid. So this study that we set out to do in 2020, 2021, was a mixed method study of xylazine, which I would hope kind of exemplifies this mixed methods research model that I kind of laid out earlier in the talk. So the core initial kind of insight that xylazine was a big deal came from the ethnographic team, which was embedded in Philadelphia in the mid to late 2010s. And then this triggered a kind of systematic data search for any evidence that xylazine was being kind of systematically found in overdose deaths anywhere else in the country. Here's a picture of the ethnographic field site on the right. And so here's some of the early kind of ethnographic data, which clued us into the idea that xylazine was like a very important additive to fentanyl, that it was really changing like the nature of the experience of using illicit fentanyl. So one person told us, kind of explained to us why maybe xylazine was being added in such large, in such a prevalent way to fentanyl. This person told us, I like xylazine because fentanyl is such a short-lived high. The nod is over real quick and you get sicker faster. But see, tranq extends the high. It gives the dope more of a heroin-like effect. This is something that came up a lot, that one of the key reasons to add, a lot of the crazy new things that we're seeing added to fentanyl is because fentanyl wears off so quickly. And some of these things that can be added can kind of prolong the onset of withdrawal symptoms. On the topic of soft tissue infection, someone told us, as we know that this is a longstanding issue, someone told us, I got some friends out here that got really torn up by it. They have holes in them, abscesses. Basically, it's like the body is rotting. People here are losing limbs, like with gangrene. Whatever they're doing with the tranq, everybody is getting these scabby sores all over their bodies. And then on the risk of overdose, came from a harm reductionist who told us that the number of people they were reversing, meaning administering naloxone to, was definitely going up. There were people who would become only minimally alert and slightly responsive to Narcan. So that definitely concerned us that something different was happening. There were non-opioid agents involved. We did a lot of Narcan training, and we had to focus more on the necessity of doing rescue breaths instead of just Narcan. So again, these are kind of early insights into this idea that like there was going to need to be a different clinical response to xylazine, and that has certainly borne out to be true. So this triggered a data search. We basically paired with Dr. Chelsea Shover, who was running this epidemiology lab and who had access to like very detailed records from medical examiners' offices all over the country. At that time, there was no recognized like ICD-10 code or any way that like the centralized CDC databases were actually tracking xylazine. And so we just went out and looked like in the, all the free text in all of these death certificates from these 10 places. And we ended up finding an increasing prevalence of xylazine over time. So here, one box is like, oops, one box is one location. And we found data from these 10 places. And then one bar is like per year. And it's just the number of xylazine involved overdose deaths per year. And you can see that pretty much everywhere that xylazine lands, we note that there's an increasing time trend. And then here's the same 10 places, but just shown on a map, and we can see the largest prevalence of xylazine was found in Philadelphia, which makes sense, and then it's kind of spreading out from there. So coming back to this model of mixed methods research, in this paper, we first had an initial qualitative insight from our field site here in Philadelphia, talking about the rise of xylazine and some of the health effects that were documented. This qualitative research triggered a quantitative analysis, and we did in fact find that this is a national issue. And this was actually like essentially the first paper to show the national spread of xylazine. Since then, there have been many that have like replicated that finding. And then the dissemination, we put out a preprint. We tried to get the word out as quickly as possible because we felt like this was a really urgent public health issue. Then we wrote like we published in a traditional peer-reviewed journal. And then Philippe and I also wrote in popular press about this issue. And so this is kind of the full model that increasingly I like to use in my work. So since then, xylazine has continued to spread nationally. Here is some data from a preprint showing on the y-axis here, you can see the xylazine-involved death rate per 100,000, and there's one dot per month. And you can see that over time, the xylazine-involved death rate has really steadily marched up and up. And even in just the past 2 years since that initial research was done, there's been a huge increase in xylazine-involved deaths. It's important to note that there are some racial and ethnic inequalities in xylazine-involved overdoses, that this is an issue that's disproportionately affecting Black and African Americans here. You can see the breakdown over time and by race and ethnicity. And then we can also break it down by state, and we can see that xylazine does remain more predominant in the Northeast, but is increasingly affecting a bunch of other states. And now it's found in virtually every state in the country. And that brings us to more recent work that I've done, which is about xylazine arriving to Southern California and also to Tijuana, Mexico. So this is, because the Center for Social Medicine is located in Los Angeles, I thought this might be of interest. This is like the very latest data from the Los Angeles drug checking team that I still work with about xylazine in LA. And here on the y-axis, you can see the percent of fentanyl samples tested by this drug checking program in LA that test positive for xylazine. So back when we initially, put out this first paper in 2022, there was virtually very, very little xylazine in Los Angeles. And then what we can see is really just over the past year, xylazine has like fully arrived to LA. And in the latest data, it's something like 20 to 30% of fentanyl samples in LA have xylazine. So this is now an issue that we're going to have to deal with locally as well. And these are two different articles that I've worked on in collaboration with Casa, which is a harm reduction clinic in Tijuana, looking at actually detecting xylazine in Tijuana, and then also publishing a report about like updating kind of clinical overdose response protocols in response to the arrival of xylazine. So this first paper was just a little pilot study at Casa at this harm reduction clinic where they, it's a syringe exchange. They also offer naloxone, and then they offer completely free healthcare to a pretty broad swath of folks who don't have access to other healthcare services in Tijuana. This was just a small study with 23 participants who, as part of their healthcare, both participated in like urine testing for xylazine and then also participated in drug checking, so provided like a drug sample for testing. And virtually all of the people use 100% of the people report using fentanyl. That's just the patient population. 92% of people use meth. And then the majority of people also occasionally will use black tar heroin and often prefer it when they can still get it. And the way that this population looks is mostly male. The average age was about 40. And we noted that 30% had some kind of skin wound when we during this visit, right? This healthcare visit. So this figure is a little complex, but basically each column is just a participant, like a study participant, and each row here is a different drug that we tested for, and these are just urine testing results, right? So these are people who were just basically curious to know what they were being exposed to, because if you ask them like, what do you use? They'll just be like, I use China White and meth. And we were just curious to see what else would pop up, including xylazine. We used two different brands of xylazine test strips. These are like very cheap $1 strips that can tell you if xylazine is present in urine or in a drug. And we found that like about 80% were positive on one brand and about 60% were positive on the other brand of testing strips. Then we did the same thing on the actual drug paraphernalia that the participants provided, and it was still a fairly high rate of xylazine positivity, but a little bit lower with the two different brands. And then we actually were able to send off some of the drug samples for mass spec confirmatory testing. And we found that it was about 50% of the samples had xylazine. So the overall takeaways here is just that xylazine is present in Mexico. This is an important thing for the public health response in Mexico. It's interesting that there was a higher rate of positivity on urine tests relative to the actual like drugs themselves, and that's probably because people like buy drugs from a bunch of different sales points, and so it's like there's more xylazine in their body than any given sample, right? Because their urine reflects like a bunch of different like samples that they purchased. This kind of also shows like it's a little concerning that there's like discrepancies between the different brands of xylazine testing strips. And I think the more I learn about the new testing strips, the more I realize like they're an imperfect technology. There can be false positives, false negatives. It's a helpful thing like for a community to have in general to be able to get a sense of if a new drug is an issue. But in terms of like any given person's ability to like make safer choices for themselves, it's not perfect at all. And we just need more information to really understand the performance of testing strips. So now I want to talk about the clinical management of xylazine-involved overdoses. I think this is something where it can be really helpful to understand the experiences of people who go through xylazine-involved overdoses to like minimize the iatrogenic harm of an overdose response, and also, of course, do everything we can to save the person's life, right? This is the second paper looking at the clinical response piece. There's 3 case studies in this paper. The first one is a 61-year-old male who uses opioids and methamphetamine, who's in a wheelchair, and he was just found down, cyanotic, low respiratory rate, received 4 milligrams of intranasal naloxone, and began to breathe again, began respirating. At that point, pulse ox showed 95%. The patient was not responsive, right? And this is critical, that now we're seeing the patient is alive, they're respirating, but they're still not conscious. And I don't know how many folks in the audience have ever given Narcan to someone and then had them not wake up, but it is like a very anxiety-inducing experience to have a patient who is overdosing and they're like not awake talking to you. You're going to be worried that they're about to die and you're going to want to give more Narcan, even though you're seeing on the pulse ox that they're alive. But we did not give more Narcan. Instead, the patient was monitored for 20 minutes. And then they actually awoke agitated, confused, and endorsing withdrawal symptoms, right? And this, we know that crippling, devastatingly severe withdrawal symptoms are common with 4 milligrams of intranasal naloxone. It's a very large dose, useful in the field, but in a hospital setting, this would be like a very large initial dose. And because of this agitation and confusion and the withdrawal symptoms, the patient entered the roadway and again lost consciousness, and then was, of course, exposed to risk, and actually was brought into the clinic by some of his friends who were close by for post-overdose monitoring. At this point, he provided a urine sample and also a drug wrapper, and both tested positive for xylazine. Um, Next case is a 28-year-old who just uses methamphetamine, doesn't use fentanyl regularly, found down. He was observed uh, to be smoking something out of a glass pipe prior to losing consciousness. So he was actually not arousable. He was unconscious, but his oxygen saturation was 81%. His heart rate was 92. Blood pressure and glucose were fine. So essentially, this is someone who is like alive, who's clinically stable, who's just unconscious, and we're not able to rouse them. So this is somebody who did not get naloxone, thankfully, and who was just given oxygen through a portable oxygen concentrator. His O2 sat rose to 100%. He was monitored for 40 minutes. He endorsed actually on this occasion having used some China White, meaning some like fentanyl, in this case with xylazine. And then he just declined further healthcare and left the clinic. And then he was stable 1 week later. And the important takeaway here is that this is somebody who, because they used xylazine, was not arousable, but actually we did not have to use Narcan because he was clinically stable. Last case, this is somebody who was found sitting on a curb, leaning against a car, not responsive, laid flat on the ground, was noted to be cyanotic, so it's an opioid-involved overdose. In this case, was given a much lower dose of naloxone. This was intramuscular naloxone, 0.4 milligrams. This is kind of the old school Narcan that harm reductionists used to use before the intranasal form was common. And then within 2 minutes, his O2 sat rose to 99%. Like our other patients, he remained unresponsive for a period of time. He was placed in recovery position, his vital signs were monitored, and after 12 minutes, he became alert. He accepted post-overdose care. He did not get agitated and was not endorsing withdrawal symptoms. And I think this is really critical that we gave him a much lower dose of Narcan, and he ultimately did a lot better than the first patient. And he provided a sample of prepared China White in a syringe, and it tested positive for fentanyl and xylazine. So I think like looking across these different case studies, the main thing is that, again, that kind of anxiety that I was speaking to as the provider or as like the overdose response person, as the harm reductionist, to see someone who has overdosed and they're not able to talk to you, and even though you've given them naloxone, they're saturating well. There's this big temptation to give more Narcan, and I think we can just see through these cases and through a lot of other cases, not reflected here, that the more Narcan you give, the person's not going to wake up any sooner because the thing that's keeping them unconscious is xylazine. It's not an opioid, but when they do finally wake up, they will be very, very uncomfortable the more Narcan you give. And so what the team kind of developed this protocol. This is like a community-based, like, this is an overdose response protocol for a community setting. So not in the hospital, but I think a lot of the elements of it pretty similar. So the team learned to depend on field pulse ox. These are just battery-powered little pulse oxes that can use in the field, so we can convince ourselves that the person is actually alive, even though they're not conscious still. Titrate naloxone to oxygenation status, not to level of consciousness. We increasingly were using portable oxygen. Scene safety is super important. So these people who are unconscious because of xylazine are unable to keep themselves safe. They're vulnerable to being run over by cars, to assault, to theft. And so it can be helpful to just have extra people on hand to just make sure everybody is safe until they wake up about 10 to 40 minutes later. Xylazine testing strips are a potentially very helpful technology. I think at the very least, they're helpful in having a discussion with folks about what is xylazine, but they're not perfect. So it's important to, offer them to people, I think is a good thing to do, but also teach them like there can be false negatives, there can be false positives, and confirmatory testing is really helpful. So I'll just finish with some information about drug checking technologies. So I think there's like 3 different kind of levels here of like cost and sophistication. There's drug checking strips. These are just like you dip them in a drug sample or in urine and they tell you there either is or is not that drug present. There's FTIR spectroscopy that you can see on the right here, which is like about a $40,000 to $50,000 machine. It's portable and it can provide real-time results about the drugs that are present in somebody's sample. But it has some limitations, like it can only detect things that are at 5% or more concentration in the drug. So, some of these really potent agents can be at less than 5%, be undetectable, but still be like very potent and important. And then you can, of course, like swab a drug, send it off in the mail to a lab. They can do mass spec, and a week later they'll tell you absolutely everything that's in it down to like 0.0001, 0.0001%. But unfortunately, by that point, the person's already done the drug. So it's a little bit less helpful to the person, even though it's helpful to kind of epidemiology to understand what's going on. So with that, I'll finish up and appreciate the opportunity to see everyone and happy to discuss anything that's of interest.
Might have time for one fast question. Who gets it?
Well, we can also discuss later in more
Maybe we
detail.
could gather some questions, just.
We could just ask a few questions is
Just
what we
have
could
gather
do,
them
and
and
then
then
bring them up and discuss.
Oh, yeah, why don't you ask your questions? Joe, you can respond to them in 1 minute. And we keep talking about it at lunch because we have a very ambitious schedule that we're already behind on. So sorry, you guys. Let's go ahead and ask
So,
your question.
go ahead. Well, each person will ask the question. You won't have time to answer.
Okay. I was just wondering if the only fear with increased naloxone symptoms was uncomfortability for the patient, or could it be something like further engagement with the healthcare system, or like something broader like that?
Let's.
And then
I was wondering how hard it is to get quotes and testimonies from people when it comes to illicit drug usage, and how you get around people's hesitation to speak to you when it comes to ethnography.
Okay, I'm sorry, I have an ethnographic and a medical question, but I wanted to ask, in recent years, I personally have noticed in a lot of the harm reduction spaces I've been in that the word xylazine and trank is really much more prevalent than it was a couple of years ago. People are really talking about things like trank wounds or trank skin wounds. I'm wondering how that's, if you're seeing that on the ground too, in like the harm reduction and visual aid spaces you've been in, or an intern year, whenever you have time. And if like, so the vocabulary of xylazine is really changing how people are reacting to it. I've seen a lot of discourse on the word Narcan too in relation to xylazine. And then medically, I'm wondering with a lot of the data on infrared scanning devices, especially thermometers, but also pulse oxes being less effective in darker skin tones, if titrating to pulse ox, really where the single percentage matters a tremendous amount, if that affects how you would advise on the field care.
And I have just a super quick one. Joe, the findings you had on false positives, I think need to be relooked at. The problem with false positives is much more disastrous from a perspective of completely alienating someone from ever accessing harm reduction services. A false positive from a chronic user's perspective is a betrayal. And there's not really anything they can do in any case with just the test strip, because they're too sick. They can't spend the only thing they have and use it. So in that sense, it's super useful, to be able to monitor it at the wholesale levels and at the closest to resale levels. But from the perspective of the user and the way we celebrate it in harm reduction, I think it's the same forms of alienation that we created with the grotesque mistreatments of abscesses by the San Francisco General that were just cruel to human beings, which was the exact same finding that you found here. All you have to do is observe them for 40 minutes, and you don't have to mutilate their bodies and spend tens and twenties and $30,000 and avoid amputations. So that those findings are super important, and that article on the 50% versus 80% error on test strips is really important and needs to become a self-critique in harm reduction, just the way everyone in harm reduction has forgotten about the bleach. Self-critique has forgotten, and treats as sort of irrelevant the abscess mistreatments of the 1990s that were so chronic.
I have a question.
Yeah.
So, I was This is a great talk, and I was really impressed by that kind of beautiful weaving of the observation that you did with the ethnography, and then also this research that you've done now with the epidemiology. I was waiting for you to get to the experiment part, to be honest. I thought you were going down the scientific method route, and maybe that's just my mind as like a scientist, physician, and whatnot, feeling like that's where you got to go. But I feel like that could be a next step, to not just kind of offering up thoughts on clinical management, but to legitimately like locking down some ways to manage these issues. Like, should there be an amount of naloxone that's given to most patients nationwide, or should people be kind of guessing and giving multiple doses, right? I mean, that you can't really determine until you do, the randomized controlled trial, et cetera. But I feel like you're setting yourself up so well with the observational data to do something like that. And I wonder if that's in your future, or I don't know. I just feel like there could be some really clinically applicable stuff come out of this. Yeah.
You look right here. That was really good.
Sorry, I actually can't see all of you, so I'm not sure if anyone else, but these are like really, really great questions. I wish there was time for me to answer all of them. I'll put my email in this in the chat. Do I have any time left, or should we just leave it there?
Yeah, we should just leave it there.
Okay.
Thanks
Thanks so much.